Cor pulmonale is an abnormal alteration of the right ventricle of the heart due to a debilitating lung condition. It can be caused by pulmonary embolisms, primary pulmonary hypertension, ARDS, kyphoscoliosis, COPD, among other diseases affecting the lung. For this presentation, we will focus on COPD as the main cause for cor pulmonale. In COPD, individuals have narrowing of airways due to inflammation and scarring that comes with the disease. This prevents normal ventilation from occurring. Decreased ventilation leads to hypercapnia, which will cause acidosis. Hypoxemia also occurs due to the decreased ventilation hindering blood-gas exchange. Acidosis and hypoxemia together constrict pulmonary vessels and increases pulmonary vessel resistance as shown in the rightmost image. As a means to compensate for the decrease in oxygen in the system, the body increases erythropoiesis, increasing the number of red blood cells capable of carrying and delivering oxygen to the body. This, however, leads to polycythemia, which makes the blood thicker and increases the resistance in the blood vessels. In emphysema, vascular bed destruction occurs, causing endothelial dysfunction. Part of endothelial function is the release of vasodilators, such as nitric oxide. Therefore, the potential for vasodilation is diminished in individuals with COPD. Hypoxemia can also cause reduced nitric oxide production. So all of these factors mentioned previously can contribute to the development of pulmonary hypertension. Pulmonary hypertension is characterized by pulmonary arterial pressure greater than 25 millimeters mercury at rest and 30 millimeters on exertion. Normal pressures are usually between 12 to 16 millimeters of mercury. So the increase in resistance of the pulmonary arteries leads to pulmonary hypertension, which requires the heart to pump harder to move blood into the lungs. In other words, the afterload of the right ventricle is increased. Afterload is the resistance in which the heart must overcome to open the pulmonary valve to move blood into the lungs. In addition to that, increased thoracic pressure, which is characteristic of COPD, further increases right ventricular afterload. All of this requires the right ventricle to work harder to overcome pulmonary hypertension and will hypertrophy to accommodate. This right-sided heart hypertrophy can eventually lead to right-sided heart failure. So to summarize, as the pulmonary resistance increases due to lung disease such as COPD, the pulmonary arterial pressure rises and the right ventricular work increases, leading to right ventricular enlargement and eventually right-sided heart failure. The inability to pump blood normally into the lungs causes a backup of blood, an increase in volume and pressure in the right side of the heart and the venous system, otherwise known as systemic venous congestion. Increased pressure in the right ventricle will also increase pressure in the right atrium, as well as the connected inferior and superior vena cava. Because of this, organs connected to the heart via the inferior vena cava, like the spleen and liver, experience venous congestion and causes these organs to enlarge, otherwise known as splenomegaly and hepatomegaly. The lower extremities can also exhibit edema as they are connected to the inferior vena cava. The increased pressure in the superior vena cava connects to the jugular vein, and this increased pressure can cause a visible distension in the jugular vein. The decreased cardiac output results in a lower glomerular filtration rate, and therefore increases fluid retention, causing or further exacerbating edema. Other symptoms of cor pulmonale include jaundice and ascites, which is accumulation of fluid in the abdomen secondary to hepatic congestion, cyanosis, as well as third heart sound, or S3. Treatment should be aimed at resolving the responsible lung disease. To prevent the progression of COPD, smoking cessation is critical. Vaccinations are important to prevent infections that can further exacerbate COPD symptoms. Oxygen therapy can be used to treat pulmonary vasoconstriction as a result of hypoxemia, which will improve cardiac output and therefore increase renal perfusion, as well as alleviate tissue hypoxemia. Pursed lip breathing can help control hyperinflation of the lungs, which in turn decreases the thoracic pressure and subsequently lowers the afterload of the right ventricle and the work the right ventricle has to do. Medications can include vasodilation, such as calcium channel blockers to lower pulmonary pressure, beta agonists for bronchodilation and mucociliary clearance effects, as well as anticoagulants such as warfarin to prevent thromboembolisms. Lung organ transplants may be necessary for terminal phases of lung disease.